Okay, thank you all for joining us. Welcome to the final seminar for the Western Center for Agricultural Health and Safety. We're thrilled to have you with us today. We're going to slowly get started. Next slide. First, I'm going to go over a few housekeeping items. As a reminder, this seminar is being recorded. All participants are muted. Please use the chat function to submit questions for the Q&A session at the end of the presentation. We're really fortunate to have Dr. Fadi Fatala with us to facilitate the question and answer session at the end of the presentation. As Yahaida mentioned, we do have Spanish interpretation available, and so you can choose the English or Spanish icon from the interpretation language selection below, and that's that globe icon at the bottom of the screen. We also have closed captioning available. Select the CC icon below and click Show Subtitle. So I'm really happy to introduce our speaker today. We have a new graduate from UC Davis, Amjad Ramahi, who is now at Kaiser, and he is a recent grad from the Department of Biological and Agricultural Engineering to talk about his research. So I'm going to go ahead and turn it over to him. Thank you so much for being with us.
Thank you, Heather, and good afternoon, everyone. Again, my name is Amjad Ramahi, and I'm going to be sharing with you my research at UC Davis, the title of which is Biochemical and Physiological Dynamics in Ligament Injury and Healing. So we're talking about injuries to ligaments and the biochemical and physiological dynamics as they heal. So just a quick introduction on the problem at hand. Low back disorders are pretty common musculoskeletal disorders for farm workers. They primarily result from stresses on the longitudinal ligaments of the spine. Looking at some epidemiological background evidence, in California alone, there's about 600,000 farm workers that perform stoop posture work. This is a high risk for low back disorders. This type of work generates a lot of stresses on the back, and we'll go over that. In the US, the annual cost for low back disorders exceeds $100 billion. That's probably before the inflation numbers. Other ligaments, get injured. So not only like from occupational injury settings, like farm work, in sports settings and other settings. So there's interest in understanding that type of injury and healing response. Current prevention efforts are primarily focused on improved load distribution. So either changing schedules or changing the tools or the equipment that individuals use to perform their tasks, like a mechanization or robotics, and adding equipment to perform the work. When individuals get injured, common treatments include rest, ice, compression, and elevation. That's one way to provide some relief and comfort. Amongst the other ways to manage the pain or the injuries through pain management techniques, either medications or suppression of pain. Emerging treatments to address ligament injuries include platelet-rich concentrates, for shorts. PRP stands for platelet-rich plasma, and PRF is platelet-rich fibrin. The main point of this slide is there's no solid evidence or scientific evidence to show the effectiveness of current treatment methods, despite the magnitude of the problem. We have a huge problem at hand. There's not a lot of evidence to show the effectiveness of those treatments. I did mention stooped posture in farming. This is an example of that. By definition, stooped posture is bent forward and down at the waist and or bent back while maintaining straight legs. So similar to this gentleman here performing his harvesting task, sweet pea harvest. Prolonged periods of working in a stoop posture, as quite a bit of research around this topic is contributing or associated to be a risk factor for developing low back disorders. Repeated tension on ligaments. So essentially what happens, repeated tension on ligaments leads to macro damages, which triggers healing, response and inflammation. And then because people go back to work the next day and prolonged periods of exposure, they become involved in a cyclic cycle of exposure and pain and injury and micro damages. So it ends up being a cyclical event. So what happens during stoop work or stoop posture? There's a phenomenon called flexion relaxation phenomenon. And essentially at rest, what you see here in the top graph, there's surface EMG or electromyography signal. And this is the muscle activity. It's silent. There's no activity. It's standing erect. And once the person starts bending forward, the signal, the muscle activity becomes more pronounced. At some point, at an angle bent forward in that stoop posture, that's where the phenomenon occurs, which is that silent period. The muscle completely relaxes or somewhat relaxes to a point until the person goes back up to standing. And then we'll see that muscle activity kind of reignite, and then we see the activity of the muscle. So that's the muscle activity, but from a force length curve standpoint, so looking at it from like where is the force coming from when the person is going through this motion? So at rest, zero force. As the person's bending forward, it's active muscle, so it's muscle force. The muscle is generating most of the force, or all the force at this point. After a certain point where that flexion relaxation phenomena is observed, the muscle force goes down, and then the passive tissue, mainly the ligaments of the spine, pick up the force to give the total force observed. So that's what is occurring to maintain that posture during that motion. So the person's like muscles activate, silent, go back to activation. So in the meantime, the load is passing between muscles to ligaments or passive tissue. And that's when that risk of low back injury to those passive tissues is increased. That's, that silent period when the muscles aren't active. So ligaments at that point are susceptible to injury during that flexion relaxation phenomenon. So we looked at this, from, as pain symptoms reporting standpoint. So we went out to the field. We collected data on farm workers performing this task using a symptoms survey, which collects the type of pain and then where it's localized. So we did that before intervention, and then we introduced an intervention to see the effects of that. And the intervention was a device, think of it as an exoskeleton like device to allow some of the load, the upper body's weight, to be transferred through the legs, bypassing some of the structures in the spine and the back, such as the ligaments. So pain scores were high before that intervention, and then introducing the intervention, the pain scores, the total pain score is reduced. So if you're wondering what the pain score was made of or comprised of, it's the severity of the pain, the duration, and then the number of regions that the person marks as far as them complaining of pain in those regions of the body. So we looked at this, and then we figured, okay, we definitely have like potential for high risk of injury just by looking at pain symptoms. We looked at the force length curve, where we determined, okay, the force is transferring between active tissue to passive tissue. So we see that, at this stage here, this, region, the passive tissues taking the bulk of the load. So that's the ligament. So we wanted to learn more during the course of the study, learn more about the ligaments. How can we study it more, understand it better, and then be able to make plans and interventions to reduce that risk of injury during those types of exposures. So ligaments, if you're not familiar with them, they're connective tissue. They restrain bone to bone movement. So think of them as, one of my friends called them bone tape. So think of them as tape gluing bones together around a joint. So they guide joint motion and they maintain stability. They resist various forces, tension, shear, and torsion. And the main point of it is to maintain stability during motion, such as the one where people are stooped in the stooped position. So when they do get injured, clinically, they're graded from grade 1 to 3. And grade 1 is mild tear, moderate tear is grade 2, and complete tear or rupture when it is completely ruptured. So as they heal, or during the healing phases, the ligaments go through the series or the stages of wound healing, the classical wound healing stages. It starts with the hemostatic stage, and then it moves on to inflammation, proliferation, and remodeling. Those 3 stages from hemostasis, which is a platelet plug formation, so to stop the bleeding, essentially a blood clot, all the way to proliferation takes days, whereas remodeling, to restore tissue to as close as possible to original tissue structure and function takes weeks and months. So as you can imagine, a worker going through this type of work, and then disrupting this wound healing response, it ends up causing perhaps more injury, or the micro injuries end up accumulating to a more macro and macro type injury. So ligaments, the main point here is like they follow the wound healing cascade, so we can study them from that lens. This slide just gives you a quick overview of the types of treatments based on their grade. So grades 1 and 2, or submaximal tears, non-surgical treatments typically is the case. Again, we mentioned the RICE acronym, resting in ice and compression, elevation, and then non-steroid anti-inflammatory drugs. Think of ibuprofen, and then analgesic agents, pain suppressing agents that do not interfere with the inflammatory response per se, and emerging treatments that we mentioned earlier, like platelet-rich plasma and platelet-rich fibrin, or no treatment. When it comes to complete tears, surgical treatments sometimes are deployed. Some ligaments do reconnect if they are completely torn, not very often, but surgical treatments are a way to address that. The efficacy of those treatments when it comes to submaximal tears, there's no evidence on RICE and NSAIDs to be infectious. There's quite a bit of debate on that. Treatments are directed at pain management, even though we may be using NSAIDs to suppress pain if you're interfering with other healing phases, like the inflammatory phase. NSAIDs can lead to mechanically inferior repaired ligaments. So yes, you know, suppressing pain, but you may be impacting the mechanical properties of the healed ligament. And then PRF, or platelet-rich fibrin preparations or concentrates of platelets. There's emerging evidence that they show promising results on soft tissue healing. So the significance and the aim of this research is, you know, we wanted to understand, or, you know, have more complete understanding of the biochemical steps in injury and repair when it comes to ligament tissue. We needed a scientific basis for infectious treatment and prevention, and we need a comprehensive study to understand healing of ligaments under submaximal injury conditions, simulating stoop posture. So that was, you know, critical for us to understand and build our knowledge upon. We did pick the medial collateral ligament as a model to study ligaments. The MCL, the benefits of it is it's extracapsular, so it's easy to access for surgical treatments and surgical interventions, and they're widely used as animal model studies. There's a contralateral control within each animal. So there's two knees, so you can have more versatility with your study when you have that internal control. So we used the MCL as our model for ligament injury. We did create two injury models. One is a transection model simulating the complete ligament tear, or grade 3, and we did submaximal injury to the animals or the animal models using an apparatus that was designed and built here at UC Davis. The use of biochemical, histological, and gait analysis laboratory techniques was used to characterize the functional recovery of the animal. So we did gait assessments. I'll show you examples of that. We characterized ligament healing, and we assessed treatment methods using those laboratory techniques that were optimized specifically for this research. And this gives us provides us a basis to improve ligament healing. So the research conducted to address those three aims were to develop the animal models, characterize the time-dependent biochemical response, histological response, and functional recovery during healing, and also assess the impact of interventions that are commonly deployed, like NSAIDs, like ibuprofen, and then emerging treatments like PRF. What do they do, and how are they showing any difference between the two types of treatments? So this is our kind of research plan. The hypotheses we tested are, you know, the first one is PRF treated ligaments will have a faster functional gait pattern recovery. Second one is growth factors, specifically VEGF. It's a growth factor for vascularization or revascularization, will be expressed faster in the presence of PRF. And the third one is NSAIDs will slow the healing response. This was our experiment. Adult rats, we induced the injury to the animal, and then we conducted the interventions, and then conducted the experiments, the three experiments we did: gait assessments, ELISA, which is the biochemical assessment, and then the histological assessment to look at the tissue. And we followed animals at different time points. That each time point for each experiment was optimized for that specific experiment based on initial pilot studies. And our results here I'll share with you. This is the gait assessment, just showing you like kind of the experimental setup, and then the parameters that we collected. You know, with gait assessment on rodent models. It could be done manually like we did here, or it could be done in a more automated video capture type. But we collected 8 different parameters, looking at the stride of the animal, the paw imprints, and looking at the separation and how the animal walks. So think of it as, you know, if you injure your knee or your back, in this case a knee, you know, you're going to limp. So we're trying to detect if we're going to indeed capture that sort of behavior in one of those 8 parameters that are used in this type of assessment. Out of the 8, the inner toe spread, how far the middle toes are separated, ended up being the key factor or to follow. And the results show that untreated animals, no intervention, recovered after 7 days. The meloxicam, which is the NSAID, the anti-inflammatory drug that was used, recovered after 14 days to normal. And then the platelet-rich fibrin, the platelet concentrate, treated animals recovered after 5 days. So this is, you know, our observation from a functional recovery standpoint. The other experiment we did was the enzyme-linked immunoassay. It's a common biochemical assessment technique. The steps go from taking the tissue and then creating samples to be tested against a specific antibody for the study. And we tested it against VEGF, which again is a growth factor for revascularization of tissue after an injury. The results from our ELISA study or experiment show that platelet-rich fibrin or VEGF peaked. So we're looking at the peak of that factor when the concentration peaks given the treatment. It peaked at 3 days. Untreated VEGF, untreated animals, VEGF peaked at day 5, and meloxicam VEGF peaked at day 7. So this is another way of looking at the data. The time to peak VEGF, PRF, peaked first, untreated second, and then meloxicam treated last, peaked last. So in a way, PRF allows the peak of VEGF to come in sooner, whereas meloxicam or the anti-inflammatory creates almost like a time delay of concentration of VEGF to peak a few days later. The third experiment we did was looking at the histology and the tissue healing, and looking at the sham MCLs or the ligaments, sham ligaments. We looked at cellularity, fiber arrangement, and vascularity in our assessment. So this is a common way of assessing this type of tissue. So we looked at how closely packed the fibers are. So they're lined as normal tissue would. Cellularity, looking at, is there increased cellularity, and then the shape of those cells. And we also looked at the vascularity, if there's increased vascularity in the tissue. This is a healing MCL. I believe this was day 14. So you see disorganization in the fibers. You see a lot of dark dots here. These are the nuclei of the cells, and then you don't see it in this magnification, but then vascularity or vascular bundles are increased all throughout the tissue. So when we looked at this between day 3 and day 28, which was the study period, the sham injured ligaments look pretty much the same regardless of treatment. And then the injured ligament progressed throughout. So as you'd expect, the tissue is healing, but even at day 28, it still looked pretty disorganized and highly cellular. I just want to point out a couple of things here. At day 5, if you recall, to day 14, we saw functional recovery. So animals actually came back to almost normal functional recovery based on that factor, the ITS factor that we studied. However, we don't see this, at day 14, you see a pretty disorganized and highly cellular tissue still healing. The other observation, comparison with the other studies, when we looked at VEGF, days 3 and day 7 peaked. Yet there's no histological, the histological sample seems unchanged by that time. So it's still looking healing. So based on that, we figured histological assessments in the first 28 or 30 days may not be the best to investigate maximal injury or complete transection. Here I'm sharing with you the work that was done to optimize a submaximal injury design. Again, going back, we wanted to understand the full injury on ligaments, looking at complete transection, but we're also really interested in knowing what's going to happen with submaximal injuries. Can we simulate Stooped injury, submaximal injury to ligaments in a laboratory setting on animal models? And that's kind of the intent of this design. So the apparatus allowed us to secure the animal. Was prototyped multiple times to get to a point where we can actually secure the animal and induce the injury submaximally by creating strain on the MCL. The future designs of this could be automated. It could be could allow us to create cyclic type injuries as well. So we're looking at one incident of submaximal with this design, but then if we want to repeat and simulate conditions in the field, such as stoop labor, and then simulating that work schedule and breaks schedule on this apparatus, and that's a potential for improvement on this design. I'll share with you some conclusions in this slide here. So we were able to successfully develop and study an animal model to study ligament injury with different injury mechanisms, so complete transection and submaximal. The submaximal ligament injury apparatus would allow us to simulate strain injury similar to what we see in stooped posture. The evaluated treatment methods and characterized tissue response. With PRF, we saw that improved gait and functional performance, while as we saw a little bit of a delay in the meloxicam treatment. So something to be said about this or further investigated. The PRF peak to VEGF concentration also arrived sooner. So is that helpful? Is that beneficial as opposed to the delay with meloxicam in and untreated animals? So having VEGF come sooner, what's the impact of that? Is that improving the healing overall. There's more questions to answer, but overall, I think possible uses of the findings of this research which show risk of occupational exposures with submaximal injury to ligaments. So we can simulate and study ligaments based on occupational exposures that we can simulate. And then we can, based on this, perhaps recommend policy for injury prevention, work schedules as an example. It's talked about in literature. The use of mechanization and co-robotics, what's the impact of that? And the demand on workers might change with the introduction of those interventions. So can we use this to simulate that type of exposure and study and provide recommendations on optimized work schedules and co-robotic work settings. And we ultimately, if we could, using this type of assessment, recommend new treatments and further study the emerging interventions that are being proposed by either pharmaceutical companies or through scientific research. This brings me to the conclusion of my talk. I'd like to make quick acknowledgements of great individuals that helped me along my journey. Professor Fadi Fathallah, the chair of the Department of Biological and Agricultural Engineering at UC Davis. Professor Thomas Jew, he's a professor in the biochemistry and molecular biology, the School of Medicine here at UC Davis. And then professors that served on my committee, Professor King Giles, Stavros Verzane, and Blaine Christensen, and then undergraduate volunteers to help me collect data and assist with lab experiments, Amy and Jamie. I wish you the best in your careers. My lab mates, Clayton, Osman, Jessica, Vicente, Alina, and Victor. And then lab manager, Patty Edwards at the Imaging Core, Professor Van Winkle for opening her doors, and same with Dr. Pinkerton at the CHE, and Dr. Bremen at the lab phenotype, and his lab manager, Lauren. So lots of collaborators, and I owe it to everybody that's on this page. So thanks to all of you. Funding and acknowledgement, NIOSH Western Center for Agricultural Safety and Health helped fund this research. The NIOSH Northern California Education and Research Center for providing a training grant. The UC Davis College of Agricultural and Environmental Sciences, JASTRO Scholarship. Thank you for the extra funds. And of course, the department that I belong to, UC Davis Bio and Ag Engineering Department. So with that, some references here for you, and I'd like to thank you and take a pause here and then turn it back over to the moderators for any questions or comments.
Wonderful. Thank you so much, Amjad. That was really fascinating and important work. I think that we often forget sometimes that it is that repetitive action that is the most painful for farm workers every day. I'm going to actually turn it over to Dr. Fathallah to lead the question and answer. So remind everyone to please put questions into the chat. And Fadi, why don't you take it away leading the discussion, and then we'll be sure to facilitate questions in the Google Doc.
Yeah, thank you, Heather, and thank you, Amjad, for a nice presentation overview of your research. That was nicely done. I guess I'm trying to see if there are any questions so far. We haven't seen any coming in, so I'll kick started with just a quick one. What occupational or sports injuries you would correspond to the maximal injury if you would think of cases that you would see in occupational or sports situations?
Sports settings, I would think soccer players, football players, especially on the knee injuries, would be insightful on, especially on interventions and early return to the sport. So any work done around that area would be highly beneficial to simulate. Occupational settings, I would think anything that back injuries will probably be very unlikely for complete rupture, given the type of environment. However, any fast-paced and high-load type settings may be potential for that. So,
Great, thank you.
mm-hmm.
Any questions from the audience? I don't see any coming yet, but so let's go over the recommendations, and if you kind of would summarize the results, what type of recommendation would specifically from the results that you find so far, what type of policy recommendation you would translate that recommendation to?
There's a lot of very good question, Fadi. So there's a lot of I can't generalize on a lot of employers, but there's quite a few employers out there that may encourage the use of anti-inflammatory drugs. Some employers may encourage preloading, like before the day starts, preload on anti-inflammatory drugs. It seems like, based on the research, that it suppresses the natural or innate immune response to healing by inhibiting the healing response from starting or delaying it. So if we do this, I'd imagine that would be problematic for workers' long-term ability to heal from those micro injuries that may lead to macro injuries. So as a policy, probably recommendation would be to put into question the efficacy of using anti-inflammatory drugs as a way or means to over-the-counter type treatment for pain and allowing workers to come back the next day. So that might be a way to look at this.
Great. We have a question. What commodities like strawberries in agriculture are workers most likely to engage in stoop postures and labor?
Yeah, absolutely. So strawberries is definitely like one. Asparagus harvesting, it's more fast-paced, but it's definitely like in a stoop position. The pictures that I shared are sweet pea harvest. So just to name a few, those are like the ones that come to mind as the most common. Strawberry is huge in California, as you all can imagine, and that's where there's a lot of concentration of workers in one setting, performing similar tasks.
We have another question about kind of basically injury mechanism and potential for this. So what are the possibilities for improving low back injuries in like sciatic nerve problems with this kind of approach?
So the question is, what are the potential for improving work setting?
Low back injuries like sciatic nerves problems. Like I'm assuming that they meant with this approach. So.
Oh, sure. Yeah. So I think like understanding the injury mechanism and how the tissue responds to that injury is one key element to lock and understand. So to prevent, and then based on this, prevention efforts would come in. So like you can look at work schedules and simulate this work schedule to see if that would reduce the amount of injury. You can look at stretching, so not maximally leading to a point of injury, but then what is the stretching regimen would that be useful to reduce the likelihood of injury? You can look at strengthening exercises or simulate that in the animal to see if strengthening that joint and the musculature around it, would that prevent injury to the second line of defense? Like if you remember that curve, the force length curve, if you can train to reduce the exposure to soft tissue around certain joints, would that be beneficial? So those are some ways you can apply this research to reduce the likelihood of injury.
Yeah, so I think there's a question about the how common, how common both PRF or PRP being used as treatment modalities.
So PRP is more common than PRF. PRP is a liquid form or liquid concentrate. The difference between the PRP and the PRF is that the PRF is coagulated or becomes like a gel. It's all in the steps of preparation for those types of concentrates. It's all a matter of timing and how fast you centrifuge the tissue. So as far as treatments for a soft tissue, it's an emerging type of intervention. It's becoming more and more common. There's a lot of uses for cosmetics at this point. The PRP, the platelet-rich plasma. When it comes to interventions, PRP is more common. PRF is emerging to be a more more useful intervention when it comes to the different types of concentrates you can create. The reason being is that the gelified form allows localization of the growth factors you're interested in having available, and that's the point of having the platelets at one place, as opposed to injecting a liquid form that might dissipate quickly. So having a gel form allows more of a steady release, similar to a natural way of healing. And that's the reason why we picked that type of intervention.
That's great. And then there's a question about basically the kind of clash between the productivity and an intervention, basically. So some of the engineering solutions, like to stoop posture and stoop labor, like basically harvest aids, strawberry harvest aids and other harvest aids, they can be attractive to increase production, but what are some of the potential unintended consequences to the interventions and that may help ligament injuries, right? I mean, it could affect your intervention if they're increasing production, but they could unintentionally increase the risk for ligament injury.
Absolutely. So that's a really good question, because I think that's a hotly debated topic when you introduce new technology into any work setting, and especially in the farm setting, where production tends to supersede, unfortunately, sometimes the risks involved and how that bottlenecks at the workers being in a stoop position. Like, for example, not to mention robotics, but maybe 10 or 15 years ago, you saw like the platforms, like for example in melon harvesting, you have about 10 or 15 workers walking behind a platform. Everything's being packaged right then, so just keeping up with the belt and the speeds of the different workers. So that definitely is an area of concern when you introduce like co-robotics. You know, the worker will be harvesting strawberries more frequently because the robot is doing the travel, which used to be or is currently in the practice is to allow tissues to somewhat not be exposed to strain injury. So the answer to the question is optimization. So you have to optimize the entire system. You have to look at the entire system and optimize the use of those technologies with the worker being part of that socio-technical system. Like the worker has to be considered in the system. Otherwise, yes, you'll optimize production, but then you'll be at risk of losing the workers that will be picking the strawberries for you.
Great, thank you. And follow up on diet issues. So is there a diet that can help increase healing and prevent or lower chances of injuries? So can you deliver this, basically some of the treatments through diet? That's kind of the theme of the question.
Well, obviously one of the interventions is, you know, it's a pill, right? Like the anti-inflammatory drug. But as far as I think you're thinking the question, maybe thinking of diet, like as far as like, you know, food, a diet. I did attend a seminar 2 or 3 years ago about the increase, like, you know, it was geared towards more sports setting, conditioning athletes for special events or specific events to almost remake the structure of their soft tissue. Using, you know, collagen mixes, different collagen mixes, and then vitamin C. It allows more or better absorption. So that's the extent of my knowledge on, you know, that type of research, that type of application. But there is definitely talk about whether this is infectious or not. So there's debate whether it's infectious or not, but then, you know, there's our practitioners out there promoting diet as means to either increase strength or flexibility, depending on the type of sports that the person is engaged in. So there's definitely a connection between diet and the makeup of tissue that people seem to be able to produce.
Just follow up, Amjad, would there be any diet that could potentially increase platelet count or effectively a diet that will help the same effect as an NSAID?
I think, you know, like it might be like, you know, not in my scope to say if you increase platelet count, but based on my understanding, you don't want an imbalance. You don't want like a heightened number of platelets in your body, because otherwise, you know, have other diseases to worry about because they function in different ways. But so I don't really know the answer to that question.
That's a tough one, I know. All right, so and then another question about sciatic injury. So is sciatic an injury? I thought that most of the time is non-industrial. So I mean, it's an injury to the nerve, right? So, but go ahead if you want to take that.
Yeah, I'm not, you know, the expert on this, but we, you know, based on my current work, we do, you know, see occupational injuries that are attributed to sciatic nerve injury. So it's not, it may not be in the setting I was describing, but it's definitely like a potential for that injury. If there's a correlation to the causation, that's the key determining factor. Is there a causation from an occupational setting that led to that sciatic injury? And that goes for all other injuries that may be occupational.
Yeah, the sciatic nerve starts in the lumbar region and then ends in the foot. So it can be pressed in any place along the way. So it depends on what the person is doing. So they could, and the ligaments could play a factor in that, but not directly usually. So let's see. how expensive is the most effective treatment? So is it, and then a follow-up, is it widely available and is it used for anything else? So out of those treatments, or is it it's in general effective treatments?
So it seems like based on the 3 treatments that we looked at,
Yeah, exactly.
it seems like PRF is the most infectious based on what we saw. The liquid form PRP is more widely used. The platelet-rich fibrin, which would require an incision and then placement of that PRF, the gelified form, that's not commonly used. So, and then the debate comes like, having a concentrate in liquid form, is that infectious? Does that do anything? There's a lot of debate on that. So I don't know the cost, but I would imagine it's, it would be, it's not given initially, let's put it that way. Maybe it should be to allow the healing to occur. Maybe there's, a body of work that could be done around like, when should this be done? Should it be done like immediately within the first week of an injury, or wait for, that type of treatment, 2 or 3 or 4 months down the line when the person is probably not going to benefit from it because they're, damaged tissue, and they're, he can start the healing response 2 or 3 months down the line. That, that could be something to question. And availability, it's an emerging treatment, and it is used for other uses, like there's cosmetic uses for PRP, just to kind of act as a cosmetic treatment. So, because it does induce inflammation, that's really the point. So
it's for tissue repair, right? So.
Correct, yeah.
All right, the question is about safety belts, so it's a little bit corollary to this. So do you recommend the use of safety belts while working?
Not for, I would not recommend them for manual material handling, like for lifting objects. In this type of setting where it's stoop posture and there's very minimal lifting, I don't know if I would still recommend them. I wouldn't recommend them, just given that it might give a false sense of security to the person, and then you're transferring the load elsewhere on the spine, and that might cause other problems that would be better solved by looking at the macroergonomic problem, which is scheduling, use of tools and equipment, and then the work setting overall.
Yeah, and there's been a lot of studies that kind of warn, because you're altering the feedback to the muscles from the muscles, so you actually kind of suppress what the muscles are feeling. So there've been some kind of issues with belts in general, and NIOSH have written a kind of summary on this. So if you could, I think Google, whoever asked the question, Daniel, if you just Google, I think NIOSH lifting belts, I believe, or back belts, they call it should pop up. If not, I'll be happy to help out, find it. All right, any other last comments? We have only a few minutes left. Heather, do you?
Well, no, I just wanted to thank you both again. Actually, I want to take the last minute or two to invite all of you who are with us to make suggestions for future seminar speakers. This is our last seminar of the academic year, and we will be reconvening again in October, and we're going to keep the format virtual because we really like the opportunity to reach as many people as possible. We're recording these, so they're available after the fact, both in English and Spanish. And so if there's a topic or a speaker that you recommend we invite, please put that information in the chat. I'll also ask my colleagues to put the center's email address into the chat so that you can email us if something comes to you at a later date. But we want these seminars to be relevant and applicable to the work that you're doing. So please do share that information and recommendations with us. So with that, I will just say congratulations and thank you to Amjad. It's really exciting to see you having gone through the program here at UC Davis and out in the world, contributing your great knowledge and helping people stay safe. So thank you so much.
Thank you, Heather. Thank you, Fadi.
Thank you,
And
everyone.
everyone, Kara and everybody else. Thank you.
Yeah, thank you, Fadi. And thanks to everybody. Have a wonderful summer. And we look forward to seeing all of you back in October 2022. Take care. Bye.